All right, so hopefully everybody, you know, took those review assignments seriously and were able to go on MRI quiz and just kind of refresh all the stuff that we went over last semester from MRI safety, for basic MRI, image and weighting, parameters and trade-offs, up to even spin echo pulse sequences, because it had been so long since we covered all that stuff. I wanted to make sure that you guys at least saw some of the material again, were reminded of maybe some of the things that you forgot, so that when we jump into gradient echo pulse sequences, you weren't just completely like deer in the headlights. So hopefully that helped out and allowed you to kind of just refresh, get back into it so that we can hit the ground running. So today we are going to be covering gradient echo pulse sequences, but it is good to start off with just defining what a pulse sequence is, if we have forgotten. So a pulse sequence, by definition, is a series of RF pulses, gradient applications, and remember we have three gradients we're turning on: the slice select, the phase encoding, the frequency encoding gradient, and intervening time periods. So depending on how long we set our TR or our TE or our TI, these are going to give us our desired image contrast. And when we were talking about pulse sequences, and specifically spin echo pulse sequences, we didn't really have to worry about flip angle, because we were basically setting a 90-degree flip angle because our receiver coil is in that transverse plane. So we wanted to flip that net magnetic vector from the longitudinal axis 90 degrees into the transverse plane, where we get our signal, and we get the most signal from that net magnetic vector because it rotates around that transverse axis, gets taken up by our receiver coil due to Faraday's law of magnetic induction, and you get image on your screen. But now when we talk about gradient echo pulse sequences, we're going to have to consider a flip angle that is variable, or typically less than 90 degrees. So let's talk about the different areas of a pulse sequence. We have our RF pulse. It could be either an excitation pulse, a refocusing pulse, or what we call an inverting pulse for our inversion recovery pulse sequences. Our gradients are going to be spatially encoding the signal. So that's why we have an X, Y, and a Z gradient: slice select, phase encoding, frequency encoding. So that's their main responsibility. But when we talk about our gradient echo pulse sequences, they also have another task or responsibility, and that's to rephase and dephase our hydrogen spins. So then instead of having what we call this refocusing pulse 180, our gradients are going to be responsible for rephasing our spins and regrowing that signal. They're not going to do as good of a job, but they'll get the job done so that we get a little bit of signal from our excitation pulse. We're going to have time periods just the same, but they're going to be a lot shorter. So we had TRs in the realm of 300 to 700 for a T1. We had them in the realm of 3,000 to 7,000 for a T2. So when we're talking about a gradient echo pulse sequence, our TRs could be less than 200, less than 50 even milliseconds, less than 10 milliseconds. So very, very fast. And then in turn, we also get very short TEs. So that's going to allow us to get very rapid imaging. So when would we want to utilize a gradient echo pulse sequence? Like, when would you think about utilizing a gradient echo? What type of imaging? Can't hear you, Rachel.
Does it has, never mind. I don't know.
So when would we want to image very fast, to the point where, let's say, like 5 seconds, 2 seconds, 3 seconds?
With the heart?
Heart, cardiac imaging, good, because we want to reduce the motion of that heart, so we want to image very rapidly. Abdomen imaging, where we're holding the breath. Remember, we're holding the breath for hopefully like 10 to 15 seconds. So we need to image so rapidly that we get an entire pulse sequence in that 15 to 20 seconds. So typically, a lot of those images that you do for the abdomen are going to be gradient echo pulse sequences. So you'll see some of the acronyms that you normally see for an abdomen. So I know you guys haven't worked that much on abdomen, but you'll slowly get there. But there are other things. You got diffusion weighted imaging and perfusion weighted imaging, where you're imaging so rapidly that you're able to see the functioning of that brain. You're able to see blood flow go into the capillaries for perfusion. You're able to see water molecules diffusing throughout those macro and micro molecules. So you're able to see functioning physiology. So you have to image very fast. So those are some of the uses of gradient echo pulse sequences. So we also have a way of showing these pulse sequences in diagram form. So I just want to review this. So a pulse sequence diagram is a representation of each of the hardware components of the system. So we have our RF, our radio frequency transmitting pulse that's going to the patient from our transmit coil on the top line. And then we have our gradients, the next three lines. We have our slice select gradient, we have our phase encoding gradient, and our frequency encoding gradient. So these create our spatial localization, but they also are going to be required to rephase and dephase our spins in a gradient echo pulse sequence. So remember, gradients are applied, basically you're putting more current through a loop of coil, and that causes our uniform magnetic field to now be linear, where you have more of a positive end and a more of a negative end. So you have what we call a bipolar gradient. So one positive end, one more negative end. So that creates a fluctuation that is predictable in our precessional frequencies. Remember, our precessional frequencies are going to be correspond with our static magnetic field. So remember that Larmor equation really comes into play when we're talking about our static magnetic field and our precessional frequency. So our gradients cause that linear slope of those precessional frequencies, and we can do that in all three axes. So we can do it in the Y, the Z, and the X axis to get a particular slice that we want to excite. And then the last line of our diagram is our MR signal. So this is basically our transverse axis. So this is the signal we're collecting with our receiver coil. So when we turn off our excitation pulse, usually our signal starts out at 100%, but then it slowly decays. So what is this called again, where our signal has this shape to it?
Free induction decay.
Free induction decay, FID. And with a spin echo pulse sequence, we had this great 180-degree refocusing pulse. And what that allowed us to do is turn it on. It basically flips that signal that's slowly decaying, or rapidly decaying actually, flips it on its head, inverts it 180 degrees, and then it starts to regrow. So all those spins that were dephasing start to rephase and realign to be coherent. And then you get a maximum signal amplitude, and then it starts to dephase all over again. So the time from excitation pulse to peak amplitude was what? What was that time again? TR or TE?
T.
E, good. And then from 90 to the subsequent 90 was our TR. So 90, if I copy and paste this entire thing and it was 90 to 90, that's our TR. Okay. So we had different types of pulse sequences, and they're divided into two categories. We talked about all of this last semester, spin echo. So these are spins that are rephased by 180-degree refocusing or rephase pulse. And typically the excitation flip angle is 90 degrees. So we talked about a conventional spin echo or just spin echo, a dual spin echo or dual echo, a fast or turbo spin echo. And then the last spin echo pulse sequence we talked about was an inversion recovery spin echo or turbo spin echo. And we had two types, a flare and a stir. A stir nullified fat because we created what we call a short TI time. We set a short TI time. And a flare, we set a long TI time to nullify fluid or CSF fluid. So today we'll get into this. We'll talk about our gradient echo pulse sequences. And we no longer have this 180-degree refocusing pulse. The spins are going to be rephased by the gradients. And unfortunately, they're not as efficient at doing that. So we tend to get more artifacts and less image quality. Our image quality suffers a little bit with our gradient echo, but the upside to it is we're able to image very, very fast. So these are some of the types of gradient echo pulse sequences we'll talk about today. Coherent, incoherent, or spoiled, steady state free precession, balanced gradient echo, and fast gradient echo, or what we call echoplanar imaging. So before we get into that, I want to go over this diagram, these pulse sequence diagrams. All right, so if you have this, it's under modules. And quickly just go through each of the diagrams of the ones we've already covered. Okay. So we've seen this one. We already talked about this one. We don't really need to go over this again. But just know when these gradients are turned on. So remember, the slice select gradient is turned on first, phase encoding second, frequency encoding third. Your slice select gradient always turns on when your RF pulse gets turned on. So you should always see a rectangle underneath each RF pulse, okay? Because remember, we need to select and excite a particular slice and then avoid exciting all the other slices and hydrogen spins within that, outside of that slice. The next one is your phase encoding. And this has opposite polarity. That's why it's drawn above and below, because depending on your phase that you want to select, it could be a shallow slope or a steep slope, but it could be either in the positive or negative direction. So how much phase or shifting of the phase you want to happen to that hydrogen spin happens here. And then last, we collect the signal when we turn on the frequency encoding gradient. And what's another name for the frequency encoding gradient?
Readout.
Readout, because we're reading out the signal. We're collecting that signal, we're reading it out. So 90, 180, free induction decay, signal regrows, peak amplitude, TE. All right. We also discussed a dual spin echo. This was really convenient back in the day when we did a lot of proton density of the brain, but we don't really do that pulse sequence anymore. We do the flare. So this kind of has gone away. We don't really do this as often. So the flare has now taken the place of our proton density brain image. You still do proton densities of like MSK and stuff like that. But what was so great here is there was a lot of time left over between when we collected our initial echo and when we started the next TR. And so to maximize our time and to really reduce, the imaging on our patient, we decided to just add another 180-degree refocusing pulse and collect a second echo. So the first echo was collected, so we had a long TR, but then a short TE. That was associated with our proton density weighted image. And then the second echo was associated with our T2 weighted image. So we basically acquired a slice for each image every TR. So we got 2 images almost for the price of 1. So we got a proton density and we got a T2 weighted image with our dual spin echo. So very advantageous if you're still doing a proton density weighted image of the brain. Then we talked about our fast or turbo spin echo. So what we note here is this trailing train of 180-degree refocusing pulses. So this initial one was 90, but then we had 1, 2, 3, 4, 5 180-degree refocusing pulses. So that was what we call our turbo factor or our echo train length, and it was 5. So if you had a 5-minute pulse sequence up here with just a conventional spin echo, and then you now have a fast spin echo with a turbo factor of 5, what would we think our scan time would be? Going from 5 minutes down to what?
1 minute?
1.
Minute, yeah, good, because we just divide it by our echo train length. Remember our scan time equation. You divide it by our echo train length. So we have now increased the speed of our scan, and we've reduced it to 1 minute from 5. So that's excellent. So now we're really moving. The only downside to this, it could cause some blurring on our MR image. So you can see here, everything kind of happens the same. We still, our slice select gradient turns on every RF pulse. Our phase encoding gradient changes, our phase changes each time right in between our 180 degrees. So we're gonna excite, we're gonna fill a different line of K-space each TR, or each phase shift. So we're able to fill 5 lines of K-space in 1 TR period. So that's why it makes it 5 times faster. So you collect 5 different echoes. So that's how it gets its name, fast spin echo or turbo spin echo. Really knocks down our scan time. And then finally, the last pulse sequence we talked about was this inversion recovery. So instead of starting with this 90 degrees excitation pulse, we decided to start with an 180 inverting pulse. So our net magnetic vector was in the positive longitudinal axis, Z, and we flipped it completely 180 down to negative Z. So it was fully saturated. So what we do is we set a TI time to allow those tissues to recover. And whenever the particular tissue that we're trying to null crosses that transverse axis, we start the pulse sequence. And the pulse sequence from here on out looks just like our spin echo pulse sequence. So everything from here over to the right, if we drew a line right down the middle here, this would look like a conventional spin echo. So that is all the same. The only difference is this, we start with a 180 degree inverting pulse. We select a TI time, depending on if we want to nullify fat or if we want to nullify fluid. So if we want to stir, our TI time is short. If we want a flare, our TI time is long. And then finally, we did not cover this diagram, but we'll cover it. Is our gradient echo pulse sequence. And what I really want to highlight here is, what are we missing? From all
180.
That 100, good. So on this red line right here, there is no 180-degree refocusing pulse, because what is doing that job is our gradients, and particularly it's going to be our frequency encoding gradient that dephases our spins and then rephases our spins. So this frequency encoding gradient is going to be responsible for regrowing this signal. This right here, I put a little note, is not 90 degrees anymore. It's going to be less than 90 degrees, or what we call variable, because it's going to be dependent on, you know, what type of image weighting we want, whether it's a 70 degree or 20 degree or 5 degree, 15 degree. But typically it's going to be less than 90 degrees, alpha variable flip angle. But everything else looks pretty similar, right?
Did you say alpha variable flip angle?
Yeah. The alpha little fish symbol is usually how they draw variable on like tests and things like that. So the alpha symbol, yeah, like it looks like a little fish. But that just means variable. All right. So with that quick review, let's cruise on down past all the spin echo that we covered. Does anybody have any questions before we move on? Just something that maybe you didn't catch the first time. Maybe it's still kind of confusing you in any way. Now's the time. Feel pretty good about spin echo?
Can you just do a quick overview of the stir? Really quick.
Right. So stir. So stir short tau inversion recovery. That's what stir stands for. So here, so remember with our inverting pulse, we flip all of our tissues down and completely saturate them. So we almost flip them 180 degrees from the longitudinal axis. So imagine that arrow is standing straight up here. We just flip it down so that it's now pointing down. And once we turn off that inverting pulse, all of our tissues start to recover just like they did normally, like in a T1 recovery curve. And we know that certain tissues recover faster than other tissues. And due to the properties of fat, fat recovers usually the fastest over other tissues like the white matter, the gray matter of the brain, CSF fluid, you know, pus, pretty much everything. Fat recovers the fastest because it gives off a lot of energy to the lattice. So knowing that, we set a very short TI time that corresponds with when that fat recovery curve crosses that transverse axis. So this x-axis right here is our transverse axis. So when fat crosses that axis, boom, we start that pulse sequence with that 90-degree excitation pulse. And so there's going to be 0 longitudinal vector from fat. So when we flip it into the transverse plane, there's not going to be any signal from that particular tissue. So we have officially nullified fat. And all the other tissues are going to have some associated signal to it. So here's an image of stir, and look at how uniform and how fat looks on our image. Very dark within the subcutaneous fat and within the fatty marrow of the bone. Okay, so our TI time here is 100 to 175 milliseconds. And that's field strength dependent. Just like anything, it's field strength dependent when we're talking about our recoveries of tissues. So this is, I think, about a typical for a 1 Tesla magnet. So very short. So this is what the physicist sets. You don't need to worry about setting this on your scanner. This is already done by the physicist. You just run the sequence and make sure the fat looks dark. So that in turn is different from our flare. So look at how we select a TI time that is long, that corresponds with how fluid recovers and where fluid crosses that transverse axis. So our TI time at the beginning of the pulse sequence is going to be a little bit longer in the realm of 1700 to 2200 milliseconds. So now we have nullified fluid or CSF, and then look at our image. Here's our brain flare, and we know we have fluid within the ventricles, and it is completely black. So that allows us to have better contrast to noise resolution, so we can see those MS plaques that run adjacent to those ventricles. Okay, so stir, done. Usually when we're doing MSK imaging, neuro, where we're trying to nullify fat. Flare, we do neuroimaging where we're trying to visualize MS lesions. Does that help clarify that?
Yes, thank you.
Okay.
I have a quick question about running a stir. I
Yep.
know that I'm worried about metal susceptibility when they have fusion in the spine. Sometimes we'll run a stir because they're saying that if we were to run the other one, you know, it just really would give us a horrible picture.
Yeah.
So do we also run it for metal susceptibilities or?
Stir's better than what we call our chemical saturation or our fat sat, because stir is based on the field strength. Chemical susceptibility is dependent on if we have saturated fat specifically, and fat could vary depending on where it sits along our magnet. So when I describe stirs, I like to describe them as more uniform fat suppression because they do a better job at nullifying fat, and they typically have more what we call refocusing pulses because it's usually a turbo spin echo after our inverting pulse, and it does a better job at correcting or, you know, making that metal susceptibility artifact. It's not going to go away completely, but reducing the size of it. Okay. But we'll learn more about that when we get to metal artifacts and how to adjust for that. So I don't want to get too far ahead with that. But typically you do want to choose a stir when your fat sat's not working very well. You'll probably hear that in clinic a lot. All right, so let's get to this slide here. Jump ahead. Any more questions before we move on? All right, if no more questions, we'll start from here. All right, so once again, I made a table of some of the common acronyms that you're going to see when we're talking about gradient echoes. So these are the generic names, and this is how I'll describe them as we go through. We have coherent, or sometimes they're called rewound gradient echo pulse sequences. And then here is the quick acronym, and depending on the manufacturer, they differ. And of course, we can have just one uniform acronym. Every manufacturer has to kind of put their own spin on it. So you can see here. And then if you don't know what the acronym stands for, you can go down here and get the full, you know, drawn out definition of it. We'll also talk about incoherent or spoiled gradient echoes, reverse gradient echo, balanced gradient echo, fast gradient echo, but mainly when we talk about fast gradient echo, we'll talk about echoplanar imaging. So these are the acronyms, and these are the manufacturers and how they differ. So this is kind of good if you maybe print this slide out and just have an understanding of what particular scanner you're working on, so that you have, you know, an idea of what pulse sequence you're running. Because you've probably, who has seen like FISP and FAT and Flash and True FISP? Has anybody seen that type of stuff? If you've worked on abdomens, you probably have. And sometimes they rename them, so it can be a little confusing. Like the particular site might just name it like a T2 gradient echo or something like that. So it depends on the site. All right, so let's compare quickly the difference between a conventional gradient echo and a spin echo. So in a gradient echo, you're going to be using a variable flip angle. So just put here less than 90 degrees. That's what variable flip angle means. And the reason we do that is that so that we can really reduce our TR without what we call saturation. And remember, do you guys remember we had partial saturation and full saturation? So that net magnetic vector has gone from past the 90 degrees is partial, and then full 180 is full saturation. So just remember, that's what saturation means. Partial is past the transverse plane 90 degree axis. Full saturation is a full 180. And what saturation means is basically you're starting to lose signal as you become more and more saturated. Okay? You're starting to lose signal as you become more and more saturated.
Sean, can you repeat one more time what we're supposed to write there? You said right now, I'm sorry.
Partial versus full. Partial saturation meaning past the 90 degree axis or the transverse plane. So imagine a flip angle that pushes it to 110 degrees or 120. Full saturation is complete 180, like that inverting pulse. We're flipping that net magnetic vector, full 180. And what saturation means is as you get further and further away from that transverse axis, and remember that transverse axis is where we collect signal, is your signal is going to slowly reduce. Okay, so you're just not going to get a very intense or bright image for that vector. Okay. So main thing to remember is you're using a flip angle that is smaller than 90 degrees, and you're using a lot shorter TRs. All right, and you're going to be using gradients to rephase that free induction decay. Instead of that 180 degree refocusing pulse, we now have to put that responsibility on the gradients. That 180 degree refocusing pulse was usually at 1/2 TE, or what we call tau. But since we don't have that 180 degree refocusing pulse, we can apply those gradients a lot quicker. So basically, right after the excitation pulse, we can apply those gradients to refocus those spins and get some signal. So that's why we are typically having a lot shorter TRs and TEs, because we're not constrained by that 180 degree refocusing pulse. The downside to gradients being tasked with this responsibility is these gradients do not compensate for what we call magnetic field inhomogeneities. So that just means variations in the magnetic field strength. So gradients do not compensate for those as well as that 180 degree refocusing pulse. So the resultant echo displays a great deal of what we call T2 star information instead of just T2. So if you see on a scanner or on a test T2 and then the star next to it, you know you're dealing with a gradient echo pulse sequence. So always associate this star with gradient echoes. Since these sequences are very fast, we're imaging very rapidly, they're very sensitive to flow, because we know our blood flow is going very fast. Since it's very sensitive, we're going to get signal within those blood vessels. And the reason for that is our gradients are not slice selective like our 180 degree refocusing pulse. So we could basically refocus those moving spins anywhere along the bore of the magnet. So we're not constrained within a particular slice. So that's why these gradient echoes are great for angiography, where you're trying to get bright signal from those blood vessels. So if you're doing any type of angiography, MRAs, typically those are going to be gradient echo pulse sequences. So a common MRA that you probably have all done is a time of flight of the brain. So I know I've come to a couple sites where you've done the circle of Willis, where you've cut out the interior and posterior circle of Willis. That's what we call a 3D gradient echo pulse sequence of the brain. And what happens, we don't even inject contrast, but you're able to see blood flow is bright because you're imaging very rapidly. So this is diagram just showing you the variable flip angle that you might use. You're going to use a smaller flip angle in the realm of less than 90 degrees. And when that happens, you create what we call a transverse component of that net magnetic vector, but some of that net magnetic vector stays in the longitudinal axis. So it almost regrows quicker in the longitudinal plane because it never really flipped entirely into the transverse axis. So tissues tend to recover faster when you have smaller flip angles. And when that happens, you get less saturation, meaning with the next RF pulse, it doesn't get flipped past 90 degrees. So I put down here a good chart to just kind of give you a general idea of what the TRs and TEs are in comparison to your spin echo and your flip angles. So if you just draw a line right here above gradient echo, you can see your TRs. If you wanted to select a long TR, it's going to be a little bit above 100 milliseconds. A short TR, 50 milliseconds or less. A long, in quotation, TE is 15 to 25 milliseconds. Short TE is less than 5 milliseconds. And then you can see your variable flip angles here. So the combination of these things is going to give you your desired image weighting, whether it's a T1 or a T2 star. We would have to manipulate these to get that desired image weighting. Here is a diagram of our gradient echo pulse sequence. So we're missing a couple of those gradients. We're missing the slice select gradient and the phase encoding gradient. Here we're just showing you the RF pulse, the frequency encoding gradient or the readout gradient, and then your signal. So it's kind of just a condensed view of your gradient echo pulse sequence diagram. So remember, the gradient, the phase, or the frequency encoding gradient is now responsible for regrowing this signal. So what it does, it actually applies, once you turn off that excitation RF pulse, it applies this negative dephasing gradient. So that's why it dips below the line. So it's going to rapidly dephase those hydrogen spins. So that free induction decay starts to go down even faster. So see how it's not like this uniform going down in an exponential curve, it goes down very fast. But then we apply in the opposite direction a rephasing or refocusing gradient pulse to regrow that signal amplitude. So you apply it in the positive direction. So here on the right is showing you when you apply the dephasing, all the spins start to go incoherent or out of phase. But then you apply the positive lobe, and then they go back together until they're back in phase. And then you sample it at peak echo. So it works almost just the same as that 180-degree refocusing pulse, but it's not as efficient. It's not as good as getting rid of those field inhomogeneities. So your signal amplitude is not going to be as high, but you still get some signal and at a way less scan time. So our scan time is going to rapidly decrease.
Could we say that the field inhomogeneity is like the squiggly part that's not very uniform?
Yeah, you could say that, but field inhomogeneity just means the magnetic field strength is just not uniform along the entire bore of the magnet. So you would want desirably a 1.5 Tesla from the middle of the magnet all the way to the ends, but that's just not possible. When you have very big magnets, you have little pockets where you're going to get some variation in the magnetic field strength, where it could be higher at points, where it could be lower. That's what inhomogeneity means. You just don't have a very uniform magnetic field strength. And the 180-degree refocusing pulse compensates for that, but the gradients do not. So this dephasing can also be called what we call spoiling. Spoiling. So our spins are going out of phase with each other. And then this rephase lobe could be also called rewinding. So just a couple other words that you could replace that with. So here's a good drawing or diagram of the difference between T2 decay and T2 star decay. Remember, I said T2 star decay should always be associated with gradient echoes. T2 regular decay should always be associated with spin echo. So right here, we have a 90-degree RF pulse right at the beginning. This is our transverse magnetization. This is showing you our signal amplitude, and that's on the y-axis, and then this x-axis is over time. So what you've learned so far is this top line here. Your T2 decay, once you turn off that 90-degree excitation pulse, starts to slowly decay. But then at a certain point, we apply that 180-degree refocusing pulse, and then it regrows. So this T2 decay curve decays a lot slower than our T2 star decay curve that rapidly decays, because we don't have this 180-degree refocusing pulse to regrow the signal. What we do have is our gradients to refocus the signal. So it will regrow, but it will only maybe go up to about right here. So it's less, once again, less efficient at correcting for field inhomogeneities that cause this free induction decay. Okay, so I said that gradient echoes are very sensitive to flow. So that's why they're typically used in MRA or angiography pulse sequences. And the reason for that is because our gradient rephasing, you should take that R out, rephasing is not slice selective. And what we mean by that is, let's compare it to our spin echo. So imagine you did a T2 spin echo of the brain, just your normal T2 weighted image of the brain. You should have bright fluid, but if you are looking at the blood vessels, they're not going to have any signal intensity within that blood vessel. They should appear dark. And the reason for that is usually we apply a 90-degree excitation pulse, and imagine you have this red blood cell flowing through your artery here. This is your artery. This is, like, let's say, a red blood cell. Maybe that red blood cell actually was within the slice thickness when you applied that 90-degree excitation pulse. So it was within that slice. But by the time you apply that 180-degree refocusing pulse, it's now left already. So it does not, this red blood cell does not get this 180-degree refocusing pulse, so it doesn't grow back in signal. So that little spot right there is going to appear dark because it is not sensitive to flow. So this is typically what happens when we're looking at blood, when we're dealing with spin echo. So sometimes we call it black blood imaging because all our vessels look black, and that's fine. It's not like there's no blood in there. It's just we can't image fast enough for us to see blood or get signal from blood. But when we're talking about MRA or angiography, we use a gradient echo because that gradient is not slice selected. So we can rephase that spinning or red blood cell anywhere along the bore of the magnet. So even if that particular red blood cell has left the slice, we can still rephase it with our gradients to get signal to regrow and get higher signal intensity within that blood vessel. So this is a great advantage to gradient echoes because we can do MRA imaging without even injecting contrast. So think your time of flights, your MRVs, things like that, where we can see blood, moving blood compared to stationary tissues. So I've come around a couple sites where I helped you guys cut out your circle of Willis. That's what's happening here. You have blood flow that is moving and is what we call fresh compared to our stationary tissues that are, saturated, you could say. And so the blood vessels appear bright compared to the stationary tissues. So
Good question. Could you use this for cardiac then to see cardiac flow?
Exactly. So if we're looking at the blood flow through the heart, typically it's going to be a gradient echo pulse sequence. And remember, your heart's beating so fast, you want to image very fast too, but you can use a gradient echo to see flowing blood in the heart. Sometimes you use a spin echo because you want the blood flow to be black so that you can see the walls of the heart better. So we'll cover that when we get to cardiac, but depending on if you want the blood to look black or blood to look bright, you can select a spin echo versus a gradient echo, but I don't want to get into it too much. All right. So when I was talking about image weighting with a spin echo, you really only had to adjust your TR, your TE, and your TI. You didn't really have to think about anything else. So if you wanted a T1, you set a short TR and a short TE. If you wanted a T2, you set a long TR and a long TE. And if you wanted proton density, you set a long TR and a short TE. But when it gets to gradient echo, it gets a little confusing because you have to factor in a couple more things. You have to factor in those smaller variable flip angles. You have to factor in the steady state, which we'll talk about, maintaining this steady state. And then you also have to factor in this residual transverse magnetization that is created by this steady state and what we do with it. Do we sample this residual transverse magnetization or do we get rid of it? That will all affect our image weighting. And when I talk about image weighting, think T1, T2, proton density. So TE, just like in spin echo, is going to control our T2 contrast. But for gradient echo, just remember it. You should always put the star next to it. TE controls T2 star contrast. Your TR and your flip angle are going to control your T1 contrast. Okay. In the past, just your TR controlled T1 contrast, but now your TR and your flip angle are going to control T1 contrast. So your T1 weighting is maximized when a combination of TR and flip angles causes saturation of vectors. Your T1 weighting is going to be minimized when a combination of TR and flip angle does not cause saturation of vectors. And remember, saturation is just pushing that vector past 90 degrees. So the main takeaway here is flip angle TR controlled T1 contrast, TE still controls T2 contrast.
I have a quick question.
Yeah.
So sometimes on like the Siemens, we have to, we get a little message and we can choose to adjust our flip angle.
Yeah.
Does that have anything to do with what you were talking about, just so I can make the connection?
Yeah, you never really want to adjust your flip angle drastically. So the reason that gives you that option is because your SAR limits were hit. So you guys has anybody else noticed that when you hit your SAR limits, your patient gets too hot, you're at 100%. I can see top of Tisha's hand. You're at 100%. Your scanner will give you a couple options just to cool your patient down. And usually that is to reduce the number of slices, reduce your TR, I'm sorry, increase your TR, or to reduce your flip angle. So all of those factor into your SAR, or basically your heating of the patient. So unless you drastically change your flip angle, Shamarva, you're not going to see a change in your image weighting. But that would be the last option, or no, the changing your slice number would be the last option. It would be the second to last option I would do. I would always go first to your TR, change your TR, but make sure it's still within your range. If it's not, I would open that protocol back up and bump up your concatenations to 2 so that you can get more slices within a TR. So there's some options, and that's something you're going to have to, that's a good question for the technologist and kind of why that's happening, things like that. But those are usually your 3 options, but unless you drastically change your flip angle, you're not going to see any change in your image weighting. So if it says you go from 110 degree flip angle to 105, yeah, that could be an option you choose. I don't think that's going to really affect your image quality that much. Okay, a good question.
We do first level, like a lot of the times when the SARS pops up.
And
we
that's
first
totally
level it.
too, unless Tisha, you are dealing with some kind of metal or device in the body, or a pregnant patient. Anybody, because remember, when you go to first level, you potentially you're putting more stress on the patient. You're still within less than, you're heating up the patient to like a 1 degree Celsius, your core temperature when you go to first level. So that could potentially have ramifications on burns and heating and things like that. So it is an option, but if you have another option to reduce your SAR, I would choose that.
What is first level? Because they do choose that one a lot.
First level is basically saying like, okay, normal level is I'm going to scan at this level and I'm not ever going to exceed heating up the patient by more than 0.5 degrees Celsius. But if I want to venture into first level, I'm potentially heating their core body temperature by 1 degree Celsius. So you're just basically putting more RF exposure into the patient that could potentially heat up their thermoregulatory system more than it's desired. And it's never been recorded, but it could potentially cause what we call a heat stroke, where your internal body temperature gets too hot where you've malfunctioned.
I was wondering if this was like what we talked about in like safety the first semester. Like right when we began, we talked about like increasing the body by 1 degree Celsius, and then we get that alert.
Slide in that MRA safety lecture talking about the different levels. So go back to that and just kind of see what that meant by going up from normal to first level. And second level, we never do because that's just pure research. Okay, you never want to do second. But the only downside to selecting first level is if they have some devices can't be scanned at first level, because then the device will malfunction or it might heat up to the point where it burns the patient. So always be mindful of that.
I think the times we were looking at it with the flip angle, those were just really, for lack of saying this in a more technical way, fluffier patients.
Yeah.
And they were going to heat up pretty fast, but we had our incantations and everything where we could have it, they're kind of big.
Yeah, and think just fat just in normal insulates their bodies, right? So skinnier patients are able to dissipate that heat easier because they don't have that layer of fat that's keeping it in. So skinnier patients have a better chance of getting rid of all that RF exposure you're basically exposing them to you could also just wait a couple like minutes before you start the next pulse sequence. That will allow time for them to dissipate that heat too. That's always an option too, just to wait a little while, let them dissipate that heat. Turn the fan on too. I think that patient Tisha had the other day, their SAR limits were getting high. If you just turn on, get some air flux circulation, that could heat their.
Well, that patient was like wrapped in like 3 blankets. I don't know if you remember. And so we went in and we took her blankets off also.
Okay.
I don't know if that made a difference though,
But that's back to safety. So just review some of that safety stuff. I don't want to get too off topic here. All right, so when we're talking about conventional gradient echo and we're trying to get these desired image weighting, these are some of the ways we manipulate these extrinsic parameters. Remember, these are things that we can change on our MR console to get that desired image weighting. So when we're talking about wanting a T1 weighted image, we are going to select a longer flip angle or larger flip angle. And remember I said less than 90, so try not to think of 110, but around 70. Larger flip angle, and that's to avoid full recovery of our longitudinal longitudinal magnetization. And that will maximize our T1 weighting. You also want to select a very short TR so that these tissues can't fully recover. And then you want to select a very short TE so that we don't see any decay of those tissues, and that will minimize T2 star. So going back to that image weighting unit where we were talking about how to select a short TR and a short TE, it's very similar, but now we just have to factor in our flip angle. So if we desire a T2 weighted image, we're going to select a very small flip angle and then a relatively long TR and a long TE. And that will maximize our T2 weighted imaging and minimize our T1. And then if we want proton density, we're going to try and minimize both T1 and T2 star so that we get a proton density weighted image. So these are just some general, you don't need to remember exactly these parameters. Just get an idea that you usually want to maximize, if you're trying to do T2 star, you want to maximize your T2 star and minimize your T1 weighting. Over here is once again, just a diagram of our conventional gradient echo. And you can see here that the frequency encoding gradient is going to dephase and rephase those spins, and then we'll get our resulting echo. We do not have a 180-degree refocusing pulse. And then this is just showing you the T2 star decay and what's happening with those dephasing and rephasing gradients. All right. So probably one of the hardest concepts to kind of get is what we call the steady state. So I just want to make sure that everybody is reading the book on this chapter. And if you guys have the 5th edition, it's chapter 4, just to remind you guys. And then if you have the 4th edition, it's the second half of chapter 5. So chapter 4 in the 5th edition, chapter 5 in the 4th edition. So it's almost like inverted. So make sure you're reading these chapters, because this is one of these chapters you're going to have to read over a couple times to really hit it home. All right, so this steady state. This is one of these factors that help determine the image weighting in a gradient echo pulse sequence. So what it means is really maintaining almost what we call like an equilibrium phase, where the energy in equals the energy out. So the energy in is basically determined by our flip angle and how large our flip angle is. So we apply an RF pulse with a strength and duration to put energy into the patient. That flip angle flips that net magnetic vector slowly into the transverse plane. And then our energy out is determined by our TR, so our repetition time. So allowing that tissue to basically release that energy into the lattice, into the surrounding environment. So to maintain a steady state, we have to have an equilibrium of energy in to energy out. So therefore, it's critical that we select a flip angle and a TR that maintains this steady state. So our TR has to actually be shorter than most T1 and T2 relaxation times of pretty much all the tissues within our body. So that equals less than 50 milliseconds. So remember I said fat usually recovers very fast, but it recovers very fast, but it usually takes at least about 100 milliseconds for it to fully recover. So we're selecting a TR that's even shorter than that 100 milliseconds. We're selecting a TR that's less than 50 milliseconds. And then our energy in, our flip angle, is around 30 to 45 degrees. So we're not doing the full 90, we're doing about half of that. So this creates this coexistence of both longitudinal and transverse vector, because it's not fully in the transverse plane and it's not fully in the longitudinal plane. So that net magnetic vector is going to show up on both planes. And it's going to be coexistent in a very steady state. The problem with that is we'll get this what we call residual transverse magnetization. So we'll have that vector in that transverse plane, but when that next TR period happens, that magnetization will not have time to fully decay. So it's just going to be sitting in that transverse plane. And we'll either want to sample it or get rid of it, depending on the image weighting that we desire. So what we do with this residual transverse magnetization will help determine the image weighting that we desire. So this builds up since there is no time for decay over successive short TRs. This residual magnetization can be rephased by subsequent RF pulses. So our subsequent excitation pulses can produce what we call stimulated echoes. A stimulated echo is from 2 RF pulses that are less than 90 degrees. That's the definition of a stimulated echo. A stimulated echo is the result of 2 RF pulses that are less than 90 degrees. So instead of the past with like a spin echo pulse sequence where we had enough time for those tissues to fully decay and fully recover, in a spin echo, we were based on the true T1 and T2 times of those tissues because we allowed time for them to fully decay and fully recover. So it was based on true T1 and T2 times. That's different for gradient echo. We're actually on a ratio of T1 and T2. So that's because we have a component of transverse and we have a component of longitudinal. So it's going to be a ratio of T1 to T2. And whether the free induction and or the stimulated echo are sampled. So image weighting is determined by a lot of things in gradient echoes compared to spin echoes. It's determined by TR, TE, and flip angle. It's determined by a ratio of T1 to T2. And it's determined by what we do with our residual transverse magnetization. Do we sample it with a stimulated echo, or do we just get rid of it with what we call a spoiling gradient and just get rid of it? So those are the 3 things, and it was on a slide a couple slides ago, that is so important. These 3 things determine image weighting. So it's not as cut and dry as spin echo. So this is a diagram of what's steady state. I was trying to do it with my hands, but it's hard. So this is a diagram of what's going on. So remember, the energy in is the flip angle, and we want to keep it at about 30 to 45 degrees. because we want it to equal the energy out, the TR, or basically how long we allow this longitudinal magnetization to recover. So when you have an oblique vector, back to our first unit, when you have an oblique vector, it can be broken down into two component vectors where you have a y-axis vector and an x-axis vector. They're not going to be as long as this oblique vector, but you'll have a component in each plane. So that's what's happening in the steady state. This transverse component is equal or steady to this longitudinal component. And this is done by selecting a very short TR, less than 50 milliseconds, and a flip angle that is in the range of 30 to 45 degrees. So just let me emphasize this point. This doesn't happen after the first TR. It takes a couple successive TRs for this to finally create this steady state. So the pulse sequence starts, it flips 30 to 45, but then the tissues almost fully recover. But then the next time it flips, less longitudinal magnetization. And until you get to this steady state where the energy equals in equals the energy out, then you maintain this steady state. So this is after successive TR repetitions. Here's a good diagram of the stimulated echo. So this is, once again, the definition is any two RF pulses with varying amplitudes or less than 90 degrees are called stimulated echoes. So this is our first TR period with this red excitation pulse. It creates a FID. Our signal starts to decay. Then we have the next TR period, so we have another excitation pulse. This is not a 180-degree refocusing pulse. This is an excitation pulse of less than 90 degrees. Once again, we get a free induction decay that's associated with that excitation pulse. But since we had two RF pulses, what happens is this FID gets refocused by this excitation pulse. It's not a refocusing pulse, it's not 180, but anytime you have another RF pulse, it's gonna regrow the signal. So this red FID now gets stimulated to produce an echo. And what happens is it usually overlaps this next excitation pulse's FID. So you can see here, now we have FID of the third excitation pulse overlapping the first stimulated echo. So when we're talking about image weighting, it's determining, do we want to sample the stimulated echo or the free induction decay, both, or just one? That's how we're going to get our image weighting, is really what we do with this residual transverse magnetization. Okay. So if you take anything away from the slide, note this is the steady state. Draw it down here. This is the steady state. This is what it looks like. Energy in equals energy out, and you need two important parameters. TR has to be less than 50 milliseconds, so it has to be very short, and flip angle has to be between 30 and 45 degrees. That maintains that steady state. Over here is talking about the stimulated echo. This is just a slide to kind of reinforce that what we do with this residual magnetization, whether it's incoherent or coherent, gives us our desired image weighting, whether it's a T1 or a T2 star. So with that being said, this is our first gradient echo pulse sequence that we're going to come across. This is called a coherent gradient echo. So it kind of gives you an idea of what we're going to do with that stimulated echo. We're basically going to rewind those spins so that they're in phase. Coherent means we're going to rewind, that's why we have a rewinder gradient, those hydrogen spins so that they're going to be in phase or coherent. So you can see here that we have our pulse sequence diagram over here on the right. You have your phase encoding gradient, your frequency encoding gradient, and your signal. The only line we're missing is our slice select gradient. So the only thing that it would show is just basically a little rectangle anytime your RF pulse gets turned on. So that's why they didn't show it. So what happens is you turn on your RF pulse. That's variable. It's going to be 30 to 45 degrees. So you can put it right here, excitation pulse, 30 to 45 degrees. Then your frequency encoding gradient dephases your free induction decay, and then it in the negative direction, and then it turns on in the positive direction to rephase it to peak echo. On your phase encoding axis, you have this rewinder gradient to basically all those, after you've collected your peak echo at time TE, all this is doing is basically putting those spins that are slowly dephasing back in phase with each other by the time the next TR starts. So we're basically just putting these spins that are dephasing after we've sampled at TE back in phase with each other before the next RF pulse. So the resultant echo contains both information from the free induction decay and the stimulated echo. So typically the most common coherent gradient echo is going to be a T2 star weighted image. And so we maintain our steady state by selecting these parameters, but then to give our desired T2 star weighting, we select a long TE. So associate coherent with T2 star weighting. And we're sampling both the free induction decay and a stimulated echo. I have a chart that kind of quickly defines this, but if you want to write it down now, that would be important. Coherent equals T2 star. You're sampling free induction decay and stimulated echo.
Is it that we want it to be long so that we can rewind and get both of them?
No, you want it to be long to maximize the T2 decay effect. So you want to have a long TE, just like with any other TE, T2 weighted image, you want a long TE. It's to basically maximize the contrast between those tissues as they decay. All right, some advantages and disadvantages of these coherent gradient echoes is they're very fast. So you can do breath hold exams with these very fast T2 star weighted images. They're also very sensitive to flow, so you can do MRAs with these coherent gradient echoes. And they can be acquired in volume acquisition. So volume acquisition just means 3D. So put anytime you see volume, just associate that with 3D. So on your scanner, you might have come across where it says instead of a slice, increase your amount of slices, you want to increase your slab. So that's what it means by 3D. You're getting a slab of tissue instead of just a particular slice. Some disadvantages, and you'll see this consistently throughout all your gradient echoes, is you're going to have a reduce in signal because your TRs are so short. Your flip angles are really short or small, so your signal is going to go down. Your magnetic susceptibility artifact is going to go up because you can't correct for those field inhomogeneities. So if you have a metal within the patient's body, I recommend not using a gradient echo. You want to use a spin echo or like a stir because that is a spin echo versus a gradient echo. So you never want to use a gradient echo when you know that they have like a knee replacement or a shoulder replacement, things like that. And then it's very loud gradient noises because of all these things are happening. You know, you're dephasing, you're rephasing. So those gradients are being activated very fast, and usually their amplitudes are very strong. So you'll hear that noise in the machine very loud, a lot of banging. So it's going to be very loud. So this is what it looks like. Coherent gradient echo. It's T2 star. So you know, you're still looking at the fluid. We know that the CSF fluid is bright. But just look at the areas surrounding the structures. There's this black band. So it's still not the best image quality, but it gets you what you need sometimes when you're trying to do abdomen imaging. So say they're looking at the kidneys or they're looking at the pancreas. They're able to see without the patient breathing and causing that motion artifact. So they're able to see what they need to see without that motion artifact, because the motion is more detrimental than the bad image quality. So this is a T2 star coherent gradient echo.
So is it in phase or out of phase? Is it in phase?
So this is a coherent gradient echo. This particular image is what we would call an out of phase because you have this black banding. But the main thing you need to remember is this is a coherent gradient echo just in whole. And this is a T2 star because the fluid is bright. So we're not going to talk about in phase, out of phase imaging yet because that's dealing with something different. So this, on a GE scanner, a coherent gradient echo is called GRASS, Siemens, FISP, and then on Philips, FFE. So I just provided the manufacturer. And that's the same as that chart I had at the very beginning. So you could always use just that chart too, but I like to put the acronyms right next to the image so you kind of have an idea of what it looks like. All right, now we're moving on to incoherent, or just put a hyphen here, or spoiled gradient echo. So what we're going to do here is dephase or spoil, get rid of, that's what spoiling means, just get rid of the residual magnetization. So it has no effect on our image contrast or image weighting. So there's two ways that the book describes that we just basically get rid of it. And remember, I talked about our dephasing lobe can also be called spoiling. And so what spoiling means is imagine your spins are fanning out, they just fan out more. So they slowly lose signal or they dephase to the point where there's nothing left. That's what spoiling means, getting rid of that particular tissue's vector. So we have two ways to do it. We can do RF spoiling or gradient spoiling. Let's talk about gradient spoiling. It doesn't occur as often, but it's kind of the easiest to explain. It's basically we apply a dephasing lobe, and it could be on your slice select, your readout, or your phase encoding gradient, just to get rid of that particular vector of tissue or tissues. So you apply a dephasing gradient on either the slice select, read or frequency encoding gradient, or the phase encoding gradient. They didn't really draw it that well because they drew almost like a positive lobe. So imagine that's like a negative lobe. The RF spoiling is basically making sure that the FID and the stimulated echo don't overlap each other. And a way to do that is by changing the phase angle. So we know that when we collect our echoes on the transverse plane, they rotate completely around that axis. That vector kind of continuously rotates around B sub 0 in the transverse plane. So if we start a pulse sequence, say at 12 o'clock, the next TR, we might set it at 1 o'clock. And that is designed so that the free induction decay and the stimulated echo don't overlap each other because they're off phase angle just a little bit. So that's what RF spoiling means. And that is more common to spoil the residual magnetization than our gradient spoil. So just know this is more common, and we're changing the phase angle of when we excite the tissue. So we're just kind of going around our clock, each TR.
Does that give us like a clearer image?
Doesn't give you a clear image, it gives you a different image weighting. So now we're just going to collect. Now, since the FID and the stimulated echo are not overlapping each other, we're able to just collect signal from the free induction decay, which will give us T1 weighted imaging. So we have completely spoiled or gotten rid of the residual magnetization or our stimulated echo. So we're just collecting signal from the free induction decay. Gives us T1 weighted imaging. So for the parameters, we still maintain that steady state, but then we select a short TE to maximize T1 weighting. So we don't allow those tissues to fully decay, and we don't get a difference in contrast of those tissues. So we're relying more on TR and flip angle. And remember, I said TR and flip angle control T1. So we're relying more on these parameters. So this is kind of another diagram of what that spoiling gradient does. So here is that T2 decay. You could put a star next to this because remember, this is always a gradient echo. And then what it does is just basically when that spoiling gradient is applied, it rapidly decays those tissues so that there's no signal intensities from those particular tissues. So they're completely incoherent or out of phase by the next TR period. So we just rely completely off of T1 recovery of those tissues. So the test will just be like, you know, this is a T1 gradient echo. What's another name for T1 gradient echo? Incoherent or spoiled. Those are your options. A T2 gradient echo, what's another name for that? Coherent. Remember, making those associations, kind of like that matching assignment we did at the beginning of the semester. Those are the things that will get you by, especially if you're confused by these things, because it's taken me like 10 times just to read the book to really understand this. I mean, don't feel like you have to understand it in your first pass. It's not possible. I'm just going to put it there. But I need you guys to make these as quick associations. And that's why I create like these charts and things like that. All right, some advantages of our incoherent gradient echo, which is a T1. We can be acquired in volume or 2D. So breath holds possible, so we can do these. Typically our vibe is like a good breath hold T1. Good signal compared to our T2 gradient echo, and good anatomical detail, especially with our 3D volume acquisitions. And another, really highlight this one, just put a star, this can be used post-contrast. Because typically in our spin echo, we usually did T1s post-contrast. You guys see a lot of T1s post-contrast, right? When you inject, most of the time those sequences that are following it up are T1s, right? Because pathology and vessels usually appear bright on T1 after injection of contrast. So just the same here, it's a gradient echo T1, so our gadolinium is going to appear bright post-contrast. Disadvantages, same pretty much. Low signal, magnetic susceptibility artifact, loud gradient noises. So this is what it looks like. This is a T1 incoherent gradient echo pulse sequence. post-contrast, because you can see the gadolinium within that superior sagittal sinus, within the choroid plexus here, within the sulci of the brain, the meninges. So fluid is dark, so we know it's a T1. It's post-contrast because the blood vessels are bright with contrast. It's fat sat because our subcutaneous fat is dark. And just look at the image quality. It doesn't look it doesn't have good signal. It doesn't have the best resolution, but you are able to get what you needed to get. And sometimes you're going to have to do that even on a brain because patients move around and can't hold still for, the 30 minutes. So you're going to have to think critically of how I can get a good T1 post-contrast on a patient that can only maybe hold still for a minute. So this would be an option. So here are some of the acronyms depending on the scanner over here. All right. So last one before we end today, because I don't want to jam your head with too much information, is what we call a reverse echo gradient echo. That's a mouthful. Reverse echo gradient echo. So this is where we're collecting just information from the stimulated echo. So remember, stimulated echo are two successive RF pulses create a stimulated echo. And these RF pulses are less than 90 degrees. But remember, on our third excitation pulse, it creates an FID so that they usually overlap each other. So what happens here is with this reverse echo, we apply a rewinding gradient, or basically rephasing gradient that's accelerated, so it's faster. You see, applied with even more intensity than before, so that this stimulated echo occurs before our free induction decay of our third excitation pulse. So imagine we drew our third free induction decay right here. So that we're now able to separate them, and what we do is we only sample the stimulated echo compared to the free induction decay. So this is achieved by a rewinder gradient, or you could say a rephasing gradient, a positive lobe, that speeds up the rephasing, or it accelerates the rephasing so that the stimulated echo occurs sooner than it normally would. So it's now off of our free induction decay of our third. So here's what it would normally look like on top here. So you have one free induction decay, two free induction decays of these. Once you turn off these excitation, third free induction decay. But because we have 1, 2 RF pulses, it creates a stimulated echo, and it usually occurs at the same time as our third free induction decay. But if we apply this rewinder gradient right here, it speeds it up so that it now occurs here instead of here. So we have them off of each other, so they're not superimposed on each other. So this will give us more what we call T2 information compared to T2 star. So I mostly said associate gradient echoes with T2 star. That's correct, but sometimes you're able to get even more T2 information by applying this reverse gradient echo, because we're doing 2 RF pulses that are kind of like replicating a 90 and 180, but they're not 90 and 180. They're less than 90, less than 90. But it really helps boost that signal up and getting a good stimulated echo. So the images look more T2 than T2 star. So to maintain the steady state, we just keep the same parameters here. But to maximize true T2 weighting, we keep the TE as short as possible. So we want that TE as short as possible. And the actual TE is this, and the effective TE is this. So the actual TE affects the effective TE, and you can see that here by this equation. The effective TE is basically 2 times TR minus the actual TE. So you can see by definition, the actual TE affects the effective TE. The longer the actual TE, this little area right here, the shorter the effective TE. So the actual TE should be, therefore, be as short as possible to enhance T2 contrast so that your effective TE is actually longer. And we know that if a longer TE happens, we get more T2 weighted imaging. So kind of confusing in that sense, but the main things to remember is reverse gradient echo, we get T2 weighted information, and we're only sampling the stimulated echo. So advantages, you really, this line right here, you get truer T2 weighted imaging, not as good as a spin echo T2, but it's truer T2 weighted imaging than our conventional coherent gradient echo. Disadvantages are the same. This is what our image looks like. Once again, you can tell it's a T2 because you look at the fluid within the CSF. Bright. We're able to image blood, so blood flow is also bright. So the blood in the heart and the descending aorta is bright. And then here is the acronym depending on the manufacturer. So if you remember one thing, I would put a big circle around this and just memorize this chart and make those associations. So if you want a T2 star weighted image gradient echo, you need to have a coherent, and what you're doing is sampling the free induction and the stimulated echo. If you want a T1 weighted image, you're only going to sample the free induction decay, and it's called an incoherent or spoiled gradient echo. And then if you want truer, I put a little R here. It's not true T2 like a spin echo. Truer T2 weighted compared to this, you're only going to sample the stimulated echo, and that's called a reverse echo. So let's stop there because I'm exhausted. I know you guys are exhausted. I want you guys to please promise me this. If you haven't read it, read the chapter on gradient echo or the second half of pulse sequences, depending on what edition you have. And then I want you to slowly start filling out this worksheet. It's under modules, and I want you to draw these. Draw that, draw steady state, fill in this chart. And we're going to go over this next week. As we're going to finish the PowerPoint, but we're also going to go over this particular diagram document. And this will help you review for your exam in 2 weeks' time. Okay, but if you guys go ahead and just maybe try and fill this out between my PowerPoint and reading the chapter, you'll have an idea of what you really need answered if you have a question. Okay. So we make that promise?
Yep.
Yeah.
And another thing I wanted to mention, so I've changed all the echo lectures. They were all from the past semester. So that was to help you review for your assignments that were due. I've updated it to the recent material that we're covering this semester. So if you were the person that liked the echo lectures over the YouTube lectures, it's now updated, okay? And you can find always do the echo review lecture to kind of get test questions and get used to kind of questions that you might see, things like that. All right, well, you guys have any questions for me?
So Sean, next week we're gonna start with the physics instead of procedure, right?
Start with it. So we'll review this document, we'll finish our PowerPoint. We'll have any questions you might have or concerns, but you guys need to read through it once. You gotta have a baseline. You gotta have a baseline. This is something that's not gonna come as easy as maybe some of the things that you've covered in X-ray or cross-sectional anatomy. It's gonna take some time. If you feel like your head's about to explode right now, that's normal. That's how I felt. I tell you, 100% honesty, it's going to take some time for this to kind of hit home. So if you feel like you need to read it a couple times, that's totally normal. every time I read this chapter, I honestly get something new from it. So don't feel like it's going to stick the first time. But I want you guys to make an effort to just read it through it the first time, and we'll try and just kind of see where you're at next week. All right.
I do have a question for you, and I want some help with something, so I'm gonna wait. I'm not gonna quite leave when we leave.
Okay. Well then, I don't want to. Let me just stop the recording then.